Well, it looks like the witching hour has arrived and a silence has fallen over the congregation. Well, this is a very happy event. This is the Leiter lecture, which, as we all know, is co-sponsored by the Medical Library Association and National Library of Medicine, and consequently alternates in its venue. And we're lucky this year that the venue is NLM, and that MLA has completed, I guess, just about its meeting in Washington at the Hilton. And we're triply lucky because the powers that be have selected John Halamka to give the lecture. If I were to tell you all of the good things he's done and is doing, it would take away from the time allotted to him, so I won't, but I guess a few things probably ought to be brought forward. John is the Chief Information Officer at Beth Israel Deaconess Medical Center, and also Chief Information Officer at Harvard School of Medicine. They're talking together more, I guess, than they used to do. Also, he's chairman of New England Health Exchange Network. That's a whole new thing I don't know too much about. And he's chairman of a U.S. committee which is called HITSP. And I won't even try to parse all that out because he says that with the new administration it's already changed one of the letters. So progress is coming, you can see. John was an undergraduate at Stanford and simultaneously got degrees in microbiology, public health, and drifted over into bioengineering at UC Berkeley. Later, he went to medical school, in this case at the University of California, San Francisco, and he did graduate work, as I indicated, in bioengineering, residency at Harbor, UCLA Harbor, and emergency room work. So he's already completed more or less 2 lives up until now. But he joined the Harvard Medical Faculty in 1996, where all this really came together in a very timely fashion. You can see the streams coming together. And very luckily, I won't describe the other things that he's done because that's up to him to let us know what he wants. But it's enough things that you could halfway expect somebody to give a motivational lecture to you on time management. John, please tell us how you manage all these things.
The simple answer is there's 168 hours in a week. You just use them wisely. That's it. If you remember, in 1997, I was an NLM fellow, and I was here. Yes, that's right. So, and I had presented a paper on use of the internet to exchange healthcare records. And in 1997, they thought I was insane. You know, that's unstable and unreliable and insecure. Well, it's worked out okay. Well, thanks again very much for inviting me, and I had a chance to speak with Mr. Leiter and read about your father, and it's really an honor to give the lecture. 16 months ago, President Obama signed our stimulus bill, giving us $787 billion to ensure that our economic future is going to be rosy. Now, what you guys may not realize is that you are actually responsible for about $30 billion of that being used wisely. Now, spending it quickly, easy. Spending it wisely, quite hard. So what I wanted to do today in the Leiter lecture was give you a sense of what you can do to ensure those $30 billion are used to improve quality, efficiency, and safety in healthcare, because as you'll see, I've outlined 5 grand challenges, and every one of them requires the NLM and medical librarians and informaticians working together to succeed. This is the only slide that has fine print, I promise, and you don't have to read it. But this is a service, you see, because it turns out in the recovery bill, in ARA, there's 150 pages devoted to healthcare IT. And this is 150 pages on one slide. So, first idea is if we are going to exchange electronic health records to promote quality, efficiency, and safety, we better protect privacy. And I would bet every one of you has your own particular privacy preferences. It's very personal. I mean, my privacy preferences are very bizarre. I mean, my genome is published by the NIH, and you can buy my stem cells for $49. So that's a little strange. But I would guess that most of you have various ideas about privacy. So I will pick on Dr. Lindbergh for a minute. let's say that you have a medical record. A medical record might have segments in it. Standard care. You had a cold last year. No one really feels like that's too controversial. But let's imagine that there was a segment that you had in the medical record that would have something that might be controversial, like a mental health diagnosis, not that you have one, or if there was, right, or 20 years ago, that Betty Ford clinic visit, not that you ever went, but you would imagine that we would want to segment the record and decide what to share with whom and why for what purpose. And this is devilishly hard to do. So that's the first thing the stimulus bill asked us to do. And I'll show you some ideas about how to meet these challenges and how medical libraries really help. Well, the second thing is that we do want to exchange information with your consent from provider to provider for coordination of care. And there's a whole lot of good reasons to do this. I mean, Massachusetts alone, 15% of health care is redundant and unnecessary. You go to the Brigham, you get an MRI, you cross Longwood Avenue to the Beth Israel Deaconess, and you get another MRI because we can't send your results across the street. And some of this is political, some of it's a bit technical, but we want to make sure that we have a nationwide mechanism for sharing data where appropriate for all kinds of reasons. Not only care coordination, but population health and surveillance, research, clinical trials, pharmacovigilance, all kinds of things. Of course, there's a whole lot of challenges with figuring out how to architect that. Who do you trust? Do you trust your doctor? Well, probably. Do you trust the National Library of Medicine? Of course. Do you trust your insurance company? Maybe not. Your employer? Are you kidding? So hence there have to be novel mechanisms for exchanging data for all these various purposes. I'll talk a little bit about that. We want to make sure that every doc has an electronic health record. If you look across the U.S., somewhere between 15-20% of docs on average have an electronic health record. Of course, it depends what you mean by electronic health record. If you mean Microsoft Word, well, 20%. If you want something that's got wonderful vocabularies, rich decision support, and the literature, more like 2%. So we need to get the country moving on electronic health record adoption. We want to make sure that as part of protecting privacy, we record disclosures. If I were to look at your health record, well, I never would, I'd be fired. But let's just say I did, there's an audit trail of what I saw, probably. Just guessing, most systems include that. But if then, here, I'll pretend, if you're a plaintiff attorney, I'm sorry, and you assert malpractice and say, I need a copy of his record, I hand off your record to him, there's no log at all that I disclose said information. Well, if we're going to, as a country, exchange data and build databases and have all kinds of wonderful informatics and decision support, you better have the trust in the system that you could see where your data went, how it was used, and for what purpose. So figuring out how to give that to you is all about disclosure logging. Make sure that we're improving quality. Now, the whole healthcare reform, now healthcare IT reform, not very controversial, healthcare reform, slightly more controversial, is going to lead us on a path of paying for quality rather than quantity, we hope. Because today, doctors are paid for ordering more MRIs as opposed to keeping you healthy. And so if we want to do that, we better measure quality. We're going to have novel databases, novel mechanisms of giving feedback to the doctors that they're doing the right thing. They're following guidelines, adhering to best practices. So figuring out how to codify the data, measure the quality, and feedback to the payer, feedback to the provider. Got to do that. Want to make sure that devices that we might leave on the metro are indecipherable and otherwise useless, that we don't sacrifice privacy because my BlackBerry was dropped on a train. Let me tell you just how serious this problem can be. So a few months ago, I had the privilege of making the first public disclosure to the Boston Globe and the New York Times about a privacy breach that occurred at Beth Israel Deaconess. What happened was an authorized employee, this was not a hacker, this was not an MIT student, this was an authorized employee in the pharmacy, did a data analysis for decision support purposes, was so pleased with the result they copied the data analysis to a USB flash drive. Not a good idea, violation of policy. They worked for a year further at Beth Israel Deaconess, then took that flash drive to San Francisco where they got a job at UCSF. They were issued a laptop by the CIO, They copied the thumb drive to the laptop, and then the day later, the laptop was stolen. It was later fenced that week at a pawn shop, and the owner of the pawn shop opened the laptop, couldn't get it to boot, called Dell. Dell said, that's a stolen laptop, and returned it to UCSF. So the likelihood of data being compromised, extremely small. But ARA says, you better protect your mobile devices, your BlackBerries, your thumb drives, your laptops, and if you have a disclosure, you better report it not only to the patients, but to the prominent media. In our case, the New York Times and the Boston Globe. No financial information was included. This was just a number of names and ICD-9 codes, so at least credit was okay. We did report to the media everything that happened on these 2,000 patients. It just so happened it was the day of the State of the Union address, 3 hours after the iPad was announced. Sometimes you just get lucky. And we want to make sure that we record disparities of care information, race, ethnicity, primary language, and do quality analyses based on controlled vocabularies that make sure every patient that we treat in every setting gets the right care. And finally, we want to protect the vulnerable, the old, the young. We want to create repositories of immunizations, decision support, so that elderly are given appropriate meds. My grandmother was killed for a lack of an electronic health record with good decision support because she had multiple doctors who didn't share data, who didn't know what medication she was on, and prescribed medications that weren't appropriate for an 85-year-old person alone interacting with each other. They just were the wrong medications to use. You want to make sure that doesn't happen. So if those are the marching orders, so ARA says $787 billion in total, $30 billion for this, how are we going to do it? There are 5 grand challenges we need to work through. Okay, so number 1, we talked about consent. That you want to decide who should see what and when and for what purpose. Well, one real challenge in this country, we have 50 different policy-making organizations called state governments, and they all trump the federal government. They trump HIPAA. So if you were to go to Massachusetts, it turns out we can't even agree on our privacy policy on the north and the south side of the Charles River. Right? It turns out you go to Mount Auburn Hospital, which is in Cambridge. They only share data with credentialed staff members, docs who are owned and are closely affiliated. South of the Charles River, where we've said we really think care coordination is important. As long as the patient opts in, we'll share data with any clinician, even if they're in Washington, D.C. That's all okay. And so as a country, we're trying to codify, well, what are the kinds of flavors of consent? And here are the models that are currently being thought through. The one, you could opt in. We won't share any data until you tell us it's okay. 2, you opt out. We start sharing data for your care, but if you say stop, we will. Well, then you can imagine restrictions on either of those, such as it's totally okay to share all of my general care data, but not my mental health data. You know, these kinds of granular flavors, sort of a quilted consent. And then there are some places where treatment, payment, and operations they're okay by HIPAA. Just share the data. No consent required. Massachusetts is very conservative, and many states are very conservative, and they want the patient to say, opt in before you share anything. So this is great, we've got a model. Now how are you going to enforce that? So let's imagine National Library of Medicine very good at many things like vocabularies, natural language processing. We decide we do not want to share any information about substance abuse. If you look at the typical electronic health record today, it's a lot of free text. Doctors are migrating finally from unstructured text to more structured text, but it's a lot of unstructured text for now. So let's say we use the finest minds at the NLM to do natural language processing and scan all that free text. Well, they're smarter than me, but I tried doing this, and I was looking for folks who may have an issue with alcohol. So what did I find? I found a guy who has alcohol every morning. His medical record, I use natural language processing techniques. Every morning he uses alcohol to clean his skin before injecting his insulin. Oh, so I'm now going to take a diabetic skin hygiene and redact that record because it says uses alcohol, and that's the best computing that we can do in unstructured text. Well, that's not quite right. So what do we need to do? How do we come up with a model that solves all this consent? Well, I've given just a couple of examples here. In Massachusetts, we started small. Institutional opt-in. Beth Israel Deaconess has all kinds of records about you, and you decide if you want all or none. And alas, it's just too hard for the moment to carve up the record into all these various pieces and parts, so no problem. We'll hide all your data, keep it internal to the four walls of the organization if you want, or share it with authorized providers who are caring for you outside the organization if you want. So it's an institutional level consideration. And you can imagine that in the future that we could expand that to be institution with some restrictions of what's shared under what circumstance. So let's say that's focused on the place, the organization. Another example would be the use of the data. And you can imagine, again, every one of us is going to have a preference for this. I feel passionate about research. I'm actually very willing to contribute all of my medical records and my genome to clinical trials. Some people may say, care, that's important to me. But clinical trials, clinical research, I don't want to really be part of that. So fine, you could imagine codifying your medical record shared depending on how it is going to be used. Or another thought, it's again the type of data, just generally, regardless of the institution or its use, I never want my mental health data shared with anyone for any purpose, for fear of loss of employment, loss of reputation in the community, etc. Now, I will be talking toward the end of the lecture today about my personal genome, and one of the challenges when I joined the Human Genome and Personal Genome Project was, what if it showed that I had a whole bunch of genes with mental health diagnoses associated with them? How would I feel about sharing that openly? I had to sign the consent to share before I even knew what my genome would show. And now, Jim Watson actually redacted his ApoE genes, those that might be associated with an Alzheimer's diagnosis, for the reason that he just didn't want the sense of loss of his stature in the community, etc. So let's say type of data might be redactable. And finally, situation. So again, let's think about this. Suppose you have a very complex record, and it's got all kinds of things that are very private you don't want to share. You show up in the emergency department. You aren't breathing, and the doctor could save your life if only all your information were shared. My bet is most of you would agree to share your data. So it's dependent on the situation that you're in. On the other hand, you go to a dermatologist. Probably that history of the Betty Ford Clinic visit not going to impact today's blackhead. I'm guessing. Don't share it in that circumstance. So how do we go from theory to practice? Well, I don't expect you to read this, but I'm just showing you a couple of examples. What if we were able to codify in the medical record using controlled vocabularies our problem lists, our medication lists, clinical observations, and SNOMED, so you had the record quite codified, and then the NLM and folks in the medical libraries were able to codify all those consent options in a controlled vocabulary. You might imagine that you would build an XML type structure that says, for an institution called Beth Israel Deaconess, I opt in. For a use of data that goes to that Harvard clinical research thing, I opt out. Or, any data that happens to come from Walgreens Pharmacy where I get my OxyContin, my AZT, and my Antabuse, I don't want that shared. It's been a bad year. But yet, even though I don't want to do clinical trials and I don't want you to know about what medications I'm taking, if I show up in an emergency room, release everything. So if those are the examples, and this is what it just describes, I share all my data from Beth Israel, I don't want that clinical trial, I don't want the sharing, and I do opt in for emergency care. here's what we would need to do. So a medical library role is codify, as the NLM is already doing, the record, so you know how to segment it, codify the consent flavors and options in a controlled vocabulary, and then we would have persistent consent documents. And you could imagine that we could host those in your own personal health record. You could host them at your payer. You could host them with the data itself. I mean, all kinds of options. And wouldn't it be great from a clinical research perspective if you had data and consent that followed that data that told you what you could use it for? And you could imagine that even IRBs would say, I see you got your patients to consent when they originally had this test to release it to clinical trials and clinical research. That's okay. So there's still work to do on segmenting the record, coming up with these vocabularies, getting them widely adopted by clinicians. But that's a big first step, solving the consent issue. Okay. Well, here's another grand challenge we have. ARA really wants us to involve patients and families. And you'll see in the legislation that's come out, the regulation that's followed ARA on meaningful use, there's many, many places where we need to share information with the patients. The records they may have, an ambulatory visit, their lifetime record, inpatient coordination of care between a hospital, skilled nursing facility, or other place you might go after the hospital. But there's a lot of challenges with sharing data with the patient. So one great problem that we have is we don't actually know who any of us really are. Wouldn't it be great if we had a national healthcare identifier that would say, hey, Don, you're Don, and anytime we need to send you information, we know how to get your information to you. Unfortunately, we don't have such a thing. And when I was at the National Academy of Sciences talking about how we might all benefit from a national health identifier, of course, the answer was, don't go there. It's a privacy nightmare. It's a policy morass. It's a lot of frightened folks about talking about giving us another number that might someday be used to link your employment records, your tax records, your medical records. This all sounds very scary. So if we need to engage the patient and we want to share educational materials and we want to share records, and yet we don't have any unique way of identifying them, well, what might we do? Well, personal health records, certainly a start. At Beth Israel Deaconess, we have something called Patient Site, been run for the last 12 years. Every patient at Beth Israel Deaconess can get full access to all their records at Beth Israel Deaconess, and that's fine, because at Beth Israel Deaconess we know who you are. And then there are different models, such as the Google Health and Microsoft Health Vault model. Well, your data, with your consent, you can pull it from Beth Israel Deaconess, Walgreens, CVS, Quest, LabCorp into Google Health or Microsoft Health Vault and maintain a lifetime health record that's under your control there. So that's interesting. You can, Beth Israel Deaconess, have a PHR that you can go look at. It's one institution, but it's there. Google, you can push your data there. But what if we wanted to do something a bit more automatic? Wouldn't that be interesting? Oh, by the way, this is what my personal health record looks like at Google. After I've pulled all my data from all my various sources, see it has my demographics, it has my problem list, medications, allergies. All of my medical records are implanted on RFID that's implanted in my triceps. I know that sounds a little strange, but if you scan me at 134.2 kilohertz, I emit my medical record. It's very, very convenient, just bizarre. Now, I did notice that all the NLM folks have their government-issued IDs in little metal containers to prevent them from being scanned on Metro and that sort of thing. Well, I happen to have an unprotected, unencrypted RFID right here, so if you're ever next to me on the Metro, feel free to scan. It's okay, no problem. So this has worked okay, but it isn't generalizable. And so how would you generalize it? So here I'm going to propose to you an idea. What if we invent the idea of a health URL? It could be issued by anybody. Yeah, if you trust your employer, your payer, Google, whoever, they could give you a URL that you could give to your provider and say, when we're done with this visit, post the information to this URL. It's mine. And all my data is going to be gathered and aggregated over my lifetime there, and if I want to move it, I can. I control it. It's sort of like cell phone portability. This would give a patient an identifier under their control. It would be voluntary, it would be opt-in, and it would require no policy changes or regulation or debate in Congress. It is just simply a concept, a health URL that we all could get from vendors who might offer it. And the secret with this is that a health URL would provide a common front door. That is, Google, Microsoft, personal health record vendors, payers, whoever would provide one. If data were posted there would be a simple standard for getting the data into that URL and persistently storing it under your control. That's one way of getting around the lack of healthcare identifiers and engaging the patients. Well, here's what I've found. When you share data with patients, it's generally pretty hard to interpret. Your sodium is 137 today. Normal is 140. Am I going to die? Is that bad? I don't get it. Or your cholesterol is 100. Is that good or bad? What should I do about it? Well, so what you need to do is not only identify the patient, make the records accessible to them, but wrap them in very good patient-specific educational materials. So I know NLM has some projects to start thinking about patient-focused educational materials that might be used aggregated from a variety of sources, so this data becomes information and knowledge. I've absolutely found in doing this for 12 years that you have to present lab and medication data in the context of the population, in the context of knowledge, best practices, and then it's actionable to the patients. Well, only other thing to say about this is if we as a country are going to engage patients and families, it is unlikely, in my view, that we are going to create a giant database in the basement of the White House run by Sarah Palin. Not going to happen. And so what we want to do is leverage the web as it exists today, leverage Facebook, leverage all of the creative social networking kinds of tools that we have. And I would venture that as long as you put the patients in control, you will see many novel products emerging on the public internet that could use this idea of a health URL and present knowledge and wisdom and unique functions. iPhone and iPad applications. The sky's the limit. Okay. Standards enablers. Now, I know it's after lunch, it's warm outside, you really want a lot of detail about standards here, and I'm sorry about this. When I've rolled out electronic health records to 1,700 docs in the greater Boston area, one of their biggest challenges is getting the data in structured form. And they typically have handwritten notes. They've written prescriptions no one can read. They've put in problems that say elevated blood pressure, high blood pressure, hypertension. They use this different terminology for the same concept. Nothing is comparable. It's a mess. And unfortunately, a lot of the electronic health records that are out there today don't incorporate these structured vocabularies in ways that mere humans can use them. And that is, docs typically don't think of hierarchical ontologies. They don't use ICD-9 and know all of the ICD-9 codes that differentiate this or that kind of diabetes. So there are a lot of enablers that we need. Content, vocabulary, and ways of getting data from place to place. So I promise not to get too much in the weeds here. But sometimes when I am dealing with national standards through the Health Information Technology Standards Committee or its predecessor HITSP, I'm told, we just don't have enough standards. That's the problem. Well, the answer is we have too many standards. I mean, the challenge is picking the right standards for the right purpose and making them detailed and implementation guidance provided so that the vendors, all those who need to exchange data, can do so. So I will argue to you that on the content side today, if you were to ask, how do I want to exchange labs, we have a standard for that, HL 7251 implementation guide. It's good enough, it's done, it's ready to go. Clinical summaries. If I want to describe a problem list, a medication list, allergy list, an encounter, we have something called the continuity of care document. It is pretty good, but I don't know if anyone in the group has ever personally written a CCD. What you'll find is there's certain elements of that particular standard that have a learning curve. That is, it's not a completely easy thing to use, but it's a basically good enough standard. Well, we have something called NCPDP script, which is used for e-prescribing. Hundreds of millions of these transactions already flow. That's in very, very good shape. And we have a variety of administrative transactions that use the HIPAA-compliant formats for X12. So I don't think there are that many grand challenges you'll see on the content side. One of the challenges we have in the current regulations, it offers lack of detail in some places and offers choice of two standards in others. And this is actually not crazy. CCR, or the Continuity of Care Record, was a standard that was created in Massachusetts by a bunch of docs in a bottom-up way because they wanted to transition patients from place to place with a problem list, a medication list, an allergy list, and make it really easy to use. So easy that your 16-year-old child could write this no problem, didn't require a lot of healthcare domain knowledge. The folks at HL7 said, well, we really want to be able to create a standard that could represent a 94-year-old patient with a 4,000-page chart that has ICU flow sheets, everything you need, which is great. And so they developed the Clinical Document Architecture, or CDA. It just requires a lot of learning. So nirvana might be, can you somehow take that was the simple bottom-up things the docs designed and add more features like the ability to send notes, op notes, histories and physicals, that sort of thing? Or can you take this larger, more comprehensive standard and skinny it down a little bit so it's a little easier to use? Well, of course, one of the big buzzwords in 2010 is green. Everything needs to be green. And the folks at HL7 have come up with what they say is a more efficient, streamlined version of this complex standard, and they call it Green CDA. And again, not something you necessarily have to read, but it shows you, in a sense, this isn't so bad. This is XML that says, oh, okay, well, this is a patient, and this is their birthday, and this is their name. They had a problem, and this is their problem. It happens to be pneumonia, and that's a SNOMED code, and here's when it started, and here's where it ended. This kind of thing is, as a country, where we're headed. That is, take the best of what's happened from the docs bottom up, take the best of what's happened from the standards organizations top down, and make it a little simpler to use. And once you finish that, we'll have labs, we'll have meds. Everything, I think, will be good enough on the content side. Now, on the standards for vocabularies, and Betsy Humphreys is very much involved in this, we need to have a national repository for all vocabularies and code sets that's downloadable for free that is going to make every EHR in America use a common structured terminology for problems and medications, allergies, labs, these sorts of things. And so again, I think we're getting there. We're really close. So in LM, of course, you've got licensure for SNOMED CT for our country, and this is very high value. It's signs and symptoms. It's the kind of vocabularies that clinicians use in the field. ICD-9 is great for epidemiology, and it was designed for that. It's a classification of diseases. It's fine for administrative transactions. It's just not totally clinician-friendly. SNOMED is the right clinician-facing vocabulary. So embrace that. LOINC is the way lab tests are described. And so, again, make that generally available and make subsets. Clem McDonald here is working on the subsets of the most common LOINC codes that are ordered. So that way, when you order a lab, it'll be clear to the laboratory what it is you want, and when you get it back, as a result, you can compare it organization to organization. RxNorm, Crosswalk, the NLM has developed on all kinds of medication vocabularies, very good and helpful. And then as we go forward to some requirements that are coming, ICD-10, I'd rather see SNOMED in the clinician's hands and mapped to ICD-9 and 10 on the back end, and that's used for administrative purposes. Therefore, the clinician never has to see those vocabularies. Changing so much so fast and requiring meaningful use and all these new structured data transactions and constantly giving docs new vocabulary standards is a little too much too soon. So let's just use SNOMED as the only thing they have to deal with. And NLM has a huge role in making this happen. ultimately, this is all about getting structured data entry much easier so that we can segment the record, as I talked about, to protect privacy, and that we can have decision support. We can do population health and biosurveillance and protect the elderly, all those good things. Now, one challenge, and I promise this is the last slide that has acronyms on it, is getting data from place to place. Turns out is actually not as easy as it sounds. I would like to make sure that as my data goes from doctor's office or to a payer, that it's not changed along the way, not intercepted along the way, only the right people get it. I want to make sure I know who's on the other end. And in this country, we just haven't come up with one really simple way to do this. So there's a group called NEHEN Direct. There are about 200 organizations working now on a project within Health and Human Services to start answering this question. They're building a bunch of open source software, and they're trying all kinds of different approaches. Well, what if we could use secure email in a novel way of getting data from place to place? Or use technologies that are very simple that are they're called REST. And REST is a protocol that's using a web browser, using simple URLs as a way of getting data from place to place. Or use SOAP, which is a transaction that's today been used in the federal government for a lot of various data exchanges. But figure out one common way to do this. And here's again what I would argue. Pick something that's just good enough. And it is probably true, this thing called REST. Amazon uses it. Everything Google does uses it. It's used quite widely for e-prescribing in this country. It's good enough. Digital certificates so that we know who is sending the data and who is receiving the data, and fine. We've embraced the web, we've chosen a simple transaction, and we've solved the way to get it from point A to point B. That's all you got to do. And here's how it'll work. I know this is really clear, but see, no IT presentation would be good enough if it doesn't have lightning bolts and a cloud. Cloud, very, very important. It's cloud-based. This is what we do in Massachusetts today, 100 million times a year. We're using simple protocols on the internet, not any kind of leased lines or fancy technologies, to send information from provider to provider, provider to payer. Okay, so we talked about generating structured data and getting consent to share, and that there'd be some novel uses of data. Some data is for care. I just see you in the emergency department, I hope not. And I just need to get your record for that incident, for that particular episode of care. But much more interesting for our population is, wouldn't it be great if we aggregated data and could discover that Vioxx is doing harm? Vioxx causes people to have heart attacks. Or discover outbreaks, H1N1, early, instead of hearing 27 different emergency departments suddenly seeing an increase in cough. Well, how are we going to do that? So as I mentioned, one thing that's interesting about America is we just really don't trust central government data aggregation. You look at many other countries, especially those with socialized systems, sort of as a byproduct of their getting their care, the data may be aggregated in more centralized ways, and it's not going to work here. So we have to figure out who is going to aggregate it, how is it going to be aggregated. And so in Massachusetts, there are organizations that we trust to do analyses of doctors' performance, and we've delegated certain aggregations to them. I have to report on hundreds of different quality indicators. I've picked an organization that on my behalf and all my doctors' behalf aggregates data and reports on quality. So fine, we could probably figure out how to do that. Now, how do you record it? Do you record an episode of care? You came in with chest pain. We did a cath, or we did a stress test. We discovered it was gastritis. We gave you an H2 blocker. So that whole episode of care is described like today's medical record. It's more of a document. Or do we store your data in what would be called data atomic? Your problem list, your medication list, all the individual data elements, and they're all stored in a way that could be mined in novel ways. You've got to make some decisions about that. Where do I put the complexity? Do I force the doctor to have a lot of complexity? Do I force the center aggregator to have a lot of complexity? And what I mean by that is, well, it turns out that a lot of our electronic health records today don't use structured data, as I mentioned. So what happens is data extracts are made, and then The guys at the aggregation point are trying to map all these various kinds of terms, all kinds of crazy complexity, often getting it wrong. Maybe it's better to get the data right as it's close to the doctor, get it codified in a standards-based fashion, and make the aggregation very, very simple. So, what, if we're going to aggregate data, can be done? So we need to make sure that every EHR, every place that data is entered, gets structured at the point of entry, so then it's easy to aggregate. There's no special mapping or processing that has to be done at any central site. Because in America we don't trust a lot of central aggregators, keeping it very federated, keeping it as close to the doctor, the hospital, the region is probably a really good idea. So I would be comfortable with the idea that the state of Massachusetts aggregates data for public health and immunizations and then makes available from our aggregation point reports to the CDC as they might need them, because it turns out every state has their own privacy issues and their own business cases and their own unique culture. So trying to keep these aggregation points as close to the doc, as close to the original source of the data, rather than giant centralized and anonymized, is probably a good idea. Try to keeping the data as de-identified as possible is also a good concept. And what do I mean by that? Well, for a lot of the population health work we do of figuring out how many H1N1 cases there were or whether there's an association with Vioxx and chest pain, you actually don't need to know the name of the patient or where they live. So maybe it's actually okay for most of these aggregations that we keep the data without identifiers, but if necessary have an ability to relink. Should this be an infectious disease issue, you need to re-identify the patient at some later time. And typically, this is what we've done in Massachusetts, is that we keep the identities of the patients and their data in 2 separate locations. So should there be a hacking problem, that you don't have any idea whose data you're really looking at. And that's worked. And so how might we build a novel infrastructure to do this? Well, here's a couple of ideas for you. So first, storing the data de-identified, that's a great idea. But how do you deal with this problem? Dr. A orders the test, but it's never done. The patient goes to Dr. B and gets the test done. Well, hey, if we're going to ask questions about quality and outcomes and treatment, somehow we're going to have to link these records across multiple doctors. But how can we do that? We don't have a national health identifier. And I told you we don't want to store all that demographic data with the database because otherwise your privacy could be compromised. Well, here's one way to solve this. Las Vegas, now you may not believe this, but it turns out Las Vegas has much more sophisticated informatics than we do at Harvard. And what they do for all the high rollers is they have databases of who these people are and what they bet and everything they do. Believe this or not, the Bellagio and all these other guys, they're exchanging data about all these high rollers. And they store their data, oddly enough, in a de-identified form so it can't be hacked by doing the following. Let's imagine we're going to use name, gender, date of birth, let's say. Those are demographic indicators. Well, the problem with name is it's a little bit fuzzy. I mean, John could be J-O-H-N, J-O-N, Jonathan, Johnny, Jay, all kinds of things. So what the Bellagio does is they take the first name of every person and they've agreed on a common vocabulary root. Instead of storing Dick, they'll store Richard. Instead of storing John, J-O-N, they'll store J-O-H-N as the one canonical representation of the John. And then, if you've got your name sort of standardized, and date of birth standardized, gender standardized, then they hash that. That is, they create, using those data fields, a cryptographic unique identifier based on your standardized name, gender, date of birth. And they put that in the database. So it turns out that your name isn't in the database, but it is in effect a unique identifier that can be used to mix records from different organizations together so you get a total picture of you. Oh, okay. So that's an interesting way of protecting your privacy and aggregating data without putting the names there. And other ways to do it. I mean, there are all kinds of things that have been proposed, like keep data in the institutions itself. keep it in the hospital, keep it in the doctor's office. The only thing we're going to actually put out there in the cloud is a pointer to your data. So name, gender, date of birth. John has records at Beth Israel Deaconess with this medical record number. He's got records at Harvard Vanguard with that medical record number. So we've separated the data source and the index. The only problem with doing that is the index itself can be disclosing. So what if I have Beth Israel Deaconess records? That doesn't say a whole lot. What if, however, I go to Joe's Mental Health Clinic? The very presence of a medical record at Joe's Mental Health Clinic is disclosing. So maybe this idea of having what is called record locator service that has names of institutions, medical record numbers, and my identifiers here, and the data over there, it'll work for some circumstances, but not all. So let me show you another novel way of doing this, which we called Shrine. And this is currently in use at 17 Harvard hospitals, and it's been used in 60 other hospitals across the country. And this has been an NLM-funded activity. So what Shrine does is it leaves the data in the place that's closest to the doctor, closest to care, but builds a standard query mechanism so that a researcher could say, I wonder, across 17 hospitals, how many diabetics are there with blonde hair and creatinine of 5 who are on Lipitor? Well, you don't actually let the data out of the hospital. You just launch that query and it goes to a gateway that sits on top of every hospital data store, runs the query, comes back with a count or an age distribution or something that's totally de-identified, and then is aggregated to give you an answer. So this means that at the Harvard hospitals, you could do queries that used to take years in seconds by launching them in this very distributed and federated manner. And so just to show you, this is how the user interface appears. I simply pick the vocabulary controlled terms. Everything is based on SNOMED, LOINC, RxNorm, all these vocabularies I've talked about. You create Boolean queries of arbitrary complexity of ands and ors and ifs and elses, and then you launch it against all these hospitals, and in seconds it comes back with a result such as, oh, you've asked me for an age distribution of who lives and who dies, who is morbidly obese, or who's asthmatic. And here, just showing you what this means, it turns out that folks aren't born morbidly obese. It's developed over time. And so around 15 or 16, they start to show weight gain. And then around 60 or so, they start to die. Turns out morbid obesity is a bad thing to have. Asthmatics, well, actually, you can be born asthmatic. And with proper treatment, you actually live a long time. You don't see a sudden death from asthma that occurs in your 60s. So this query, this distribution of research data across 17 hospitals took 30 seconds to do. And it was just completely arbitrary. Just decide to do it, bang, there you have a result. So all of this novel aggregation and analysis of data depends upon libraries making sure the data is structured, and then that gives us the power to do this kind of data mining that protects privacy and gives us very rapid, innovative results. Okay, last challenge is decision support. So here's the problem. If you go home tonight and you read 8 articles, which I'm sure you all will, hey, by the end of the year, you'll only be 800 years behind the literature. There's more literature published in a year than a clinician can read in a lifetime. So what we need to do is bake into our electronic systems, not just here's more and more data. I've got a petabyte of data. I mean, who would have thought years ago that I would have 1,000 trillion bytes of healthcare data? What we need is the interpretation of that data, the rules, the knowledge, the best practices. What is actionable based on, oh, this med, this lab, suddenly I now know as a clinician an event occurred and here is something I should do about it. So what that requires is rules. So NLM and librarians are great at codifying data, curating knowledge, and representing that knowledge. The Beth Israel Deaconess has 2,000 clinical rules, The Brigham and Women's Hospital has 2,000 clinical rules, and they're totally different rules. Yeah, so you'll get totally different care, just depending upon where you go. Wouldn't it be wonderful if we had national, regional, domain-specific repositories that had rules about what it is that actually works, comparative effectiveness, or what are best practices? So I trained in emergency medicine in the late 80s, early 90s, and I haven't actually read my 800 articles a year that I should be doing. So, you come to me with the worst headache of life. I know I should order an imaging study. Should it be a CT? Well, that's what I ordered when I was a resident. Why? Because Harbor UCLA didn't have an MRI machine. But maybe an MRI is better. But when? Under what circumstance? I know it's more expensive, but is it safer? Not quite sure. So imagine that you had a knowledge base that said, for clinical conditions, pick a few hundred of them, here are the imaging studies that you order for a given circumstance. Oh, the patient's claustrophobic? MRI, not really a great idea. You know, they're allergic to shellfish, which is implying an iodine allergy. Probably not a good idea to give them contrast. You know, there's a whole variety of rules you'd want to fire. And what if you did that not for one hospital, but for the country? Well, imagine how empowering that would be. And so let me just show you actually a quick example of this. This is a system that we use today at Beth Israel Deaconess that does have 1,000 rules from the American College of Radiology and is consolidated across all the rule sets of Blue Cross, Harvard Pilgrim, and Tufts, our major payers, and it is a decision support web service. What happens is, I simply send to this web service, I have a 35-year-old with worst headache of life who's allergic to shellfish and is claustrophobic, and it comes back and says, oh, well, we've reviewed all the evidence out there, and by the way, this is updated every year with all the literature that comes out, and here is the test you should order, here is the evidence, here is the safety, and here is the radiation exposure of this given test. So then I, as a clinician, can look at this list and say, oh, I see, this particular test, CT abdomen, looks like it's pretty good, and, oh, but allergy to iodine, can't use it. And, oh, a lot of radiation, So it turns out, actually, ultrasound in this patient is the right thing to order for all those conditions that I've described. And this becomes completely consistent across the community. It's evidence-based, and the knowledge is updated by experts, by folks who are looking at the medical literature and curating it. And so the medical library role is empowering these decision support service providers, these knowledge bases that are going to provide the rules so that clinicians can do the right thing, acting on the data, turning it into wisdom, ordering the right test. Now, that does imply that we need also informatics support in each of our areas, pharmacy and pathology and radiology, to make sure that our systems then interface with these decision support systems, and I'm beginning to hire such people. We also want to be able to consult experts quite easily. I would encourage you to go to a site at Harvard that's called catalyst.harvard.edu. The Catalyst site has no passwords, so you can feel free to browse it. What we've done is codified using NLM all of the areas of expertise of every faculty member at Harvard. There are 18,000 faculty members, and we've been able to take their literature from Medline, and it's so nicely codified with mesh terms that we are able to identify who among the 18,000 faculty knows what. And so if, for example, I wanted to assemble a group of great geneticists that also had informatics background and knew something about pediatrics, I can actually find that in a second across 18,000 people based on what they write and what they've thought and talks they've given. Everything that the NLM may have indexed now empowers social networking. So think of this as Facebook, LinkedIn, and Plaxo for science. That's really what it is. And it's all publicly accessible, so again, it's called Profiles. You can feel free to look at it on the Catalyst site. It's a way of bringing expertise to the bedside on any topic using NLM resources. Last thing I want to talk about is the genome. So I am the 4th or 5th human to have been fully sequenced. This is the gallery of rogues of the folks who have had their full genome sequenced. There are 2 others, Jim Watson, not pictured here, and Skip Gates. And recently, like 2 weeks ago, all 12 of us gathered for a historic photograph. And Skip Gates, what a gentlemanly guy, and Jim Watson, just an icon. And so all of us have released our genomic data to the public. So everything that I am likely to develop over time is now part of the public domain. So I'll just share it with you. You know, from a HIPAA perspective, you have consent. It's okay. So I carry Charcot-Marie tooth type 4, a neuromuscular disorder never expressed in me or my family. I have a carrier state of severe combined immunodeficiency, that's the bubble disease. I'm more susceptible to tuberculosis than the average human. Now, I did actually run the multi-drug resistant TB service for LA County for a year, so I passed that particular probability. Twice as likely to develop prostate cancer as the average male. I have a negative KEL antigen, which is important. If I get 2 blood transfusions, I could get a transfusion reaction. And I have 6 genes that predispose me to glaucoma. Now, what's interesting about this in the library role is, so I have 30 billion base pairs. Sequencing is easy, and mapping those to disease states is hard. That's the real challenge. And why is that important? Well, I'm a doctor, so of course I would never seek wellness care. I mean, I don't trust doctors, right? So I haven't seen an ophthalmologist in 20 years. So I saw that I have 6 genes that predispose me to glaucoma. I went to an ophthalmologist who measured my intraocular pressures as 26 in each eye. I have glaucoma. And I would have not known that had there not been the genome and the mapping and interpretation and annotation, which so many tools are being built by NLM and others to do this, that would tell me to seek that wellness care. So I was placed on an eye drop a night, and now my pressures are 13. And remember, glaucoma is a silent cause of blindness. So I would have had blindness. I would have had macular degeneration. I would have had a lifelong issue that was prevented because of informatics and the genome. Now, when Craig Ventnor was originally doing the Human Genome Project, Celera Genomics, and Francis doing the original Human Genome Project, the cost to sequence a human was $350 million. Now, economies of scale have improved since then. Jim Watson was about $2 million. I was $10,000. And today, we are able to sequence the full genome for $500. So it turns out, when I say these are the few humans that have had their sequences done, it will be the last time in history that you will be able to fit the sequenced humans in a single room, because in the next year it will be in the thousands, in the year thereafter tens of thousands, hundreds of thousands, and millions. In a sense, sequencing the genome is almost free. It's the annotation that is still hard. So I would just encourage you to all recognize the genome is here. It's really important for wellness and patient engagement care, and that annotations in the genome using curation of the literature and applying that to the sequence is a grand challenge that's very, very important to solve. So I blog every single day, and in fact tonight's blog will be about being here. It is a blog Monday through Wednesday, typically about policy and technology. Thursday, always something strange and personal, whether it's about how to be a vegan, or I just wrote some things about alternative ways of creating compost piles. You know, it's something weird. Friday, an emerging technology. And so I always try to keep things lively. And I also have a BlackBerry strapped to my body 21 hours a day. Somebody has to do it, so I'm always happy to answer questions via email. But I do look forward to working with all of you over the next year as we spend 30 billion wisely and address some of those grand challenges. So thanks very much. Happy to answer questions. And see, I got through all of those acronyms. No one fell asleep, so that was good.
Any questions? push the button so your light goes on.
Hey, I'm an informal guy, so don't be shy. Why do I wear black? What do you do with a 2-year-old with a bean stuck in their nose? I can answer anything. Yes, question.
Sally? The first 4 of the 5 grand challenges that you outlined are perhaps more in the realm of the medical record librarian than the medical librarian. And you indicated how difficult it is to take the aggregate knowledge from the literature and try to apply it to really stage 4. I guess my question to you is, once we're able to aggregate data about our own populations, are we going to become irrelevant? Is the whole collected literature going to be useless?
Oh, absolutely not. Fear not. So let me give you an example. That one of the things that some of my folks at Harvard are doing is they're actually looking at all these aggregate data sources that once you point out could put you out of business, and asking, well, what kind of novel things can we conclude? Well, here's an interesting one. The white count of the average human at 8 in the morning is 8. The white count of the average human at 2 in the morning is 11. That's weird. Do we have cyclic variation of our white counts? The answer is no. No one orders a white count at 2 in the morning unless you have a fever, right? So it turns out we have all this aggregate data, but we have no idea why these things may be true. It is the medical literature that will give us the why.
I wonder if you could talk about your experience with trying to avoid having to do linking with chips in your arm.
With the chips in my, so avoid having to do medical record linking. Well, so again, the story behind this, because this is a strange thing to have an implanted RFID, was that 5 years ago when there was this first discussion that maybe we, because we don't have a national health identifier, and maybe we don't have this nationwide health information network, we should just all carry our medical record with us. I mean, how easy is that? So I did what anyone would do, and that is went to an orthopedic surgeon and had the RFID with my identifier, and it's a 16-digit identifier that identifies my species, human, luckily, and then unique to me, some pointers that go to a web-based repository of my data where I have collected all the things that I want to share, and by scanning this and going to this website with my unique identifier, you can retrieve that information. It doesn't hurt that much to get installed. It can basically never be removed. It doesn't affect airport travel or MRI scanners, but I can't walk into Best Buy. That's the only problem. So it turns out that all the DVDs in Best Buy are marked with 134.2 kilohertz RFID chips, and let me tell you how much fun it is to explain to the 18-year-old security guard, honestly, I'm not hiding a DVD anywhere. My conclusion after doing this experiment is it's not going to catch on. It is far easier to aggregate data on a network than it is to have an implanted chip, carry a USB, carry a smart card, all kinds of alternatives, use a PHR, and I think I'm the only clinician in America with one of these. Don't worry, you're not getting one soon. All right, any other questions? Yes?
John, could you comment on knowledge services for the public that medical libraries serve?
Right, well, absolutely. And so recognize, as I said, about sharing data with the public, that it is critical that patients get data in the context of educational materials that are written at an appropriate level for the patients. So my knowledge services organization, no longer do we use the term medical libraries, because so much of what they do is interpreting the literature from data to knowledge, is doing not only that for the clinicians, but doing it for the patients, delivering educational materials at discharge, at the bedside, and over the web as part of our personal health record. So a critical, critical need. And ideally what we'd like to do is do patient-specific delivery based on codified terminology, so I could say, here are the medications, here are the problems, now deliver me the literature that is appropriate for that patient. My questions?
John, a week or two ago at a Friends of NLM meeting, we encountered people who call themselves e-patients.
Yes.
So e-patient Dave
Dave,
is an
indeed.
example. Yeah. Have you encountered these folks, and what's your view about that matter?
Okay, so Dave, who's a good friend and colleague, and you'll love this. It's a good NLM story, honest. Dave and I had a public, I wouldn't call it battle, exchange of ideas in the Boston Globe. And so this is fast. If you search on e-patient Dave and you look at the hundreds of articles that have been written, it went something like this. I did a very, very bad thing, and that was I shared with patients all of their data, including their administrative data. Now, I don't know if any of you have ever had the privilege of looking at the data we actually send about you to insurance companies, but it's junk. It's okay this is being recorded because it's a fair statement of what happens is that we were talking about ordering radiology tests. So you come in with the worst headache of life. Oh, I learned in emergency medicine, worst headache of life, subarachnoid hemorrhage. Got to worry about that. So when I go to justify why I ordered that test, I write in subarachnoid hemorrhage. What gets sent to the insurance company is subarachnoid hemorrhage. What you had was a tension headache. And so what Dave points out is if you're going to be an e-patient and you actually are going to look at all your data, well, Dave, in the course of 1 year, he had brain cancer, renal failure, and twins. It's shocking because the disconnect between the clinical observations and the billing codes that go out is so profound that it creates misinformation. And so what I did as a result of Dave is I banned the use of ICD-9 codes and administrative data going to the patients, and now SNOMED codes and their interpretation are the only thing from doctor's brain to patient direct. So he's a friend.
That's great. Well, I was kind of amazed at the, I would say, relatively good advice that e-patient Dave got from these lay sources. I thought it was right on.
Well, the one thing you have to be very careful about is there's no curation on the internet.
Yeah.
And so when you search on the internet, you're just as likely to get the Bulgarian Journal of Irreproducible Results as the New England Journal. And that's so sure, sometimes you go to patients like me, or you go to places where informed patients, my father has multiple sclerosis, again, okay for me to reveal that, he gives consent, and it's really tricky to dose medications in MS patients because so many of their symptoms are very subjective. So it turns out the best source of information for him is other patients who have experienced the same symptoms and the same drugs. So there are novel places you could aggregate data from, but nonetheless, I feel much more comfortable about an NLM curated data source than just using Google blindly. And Jerry Groupman wrote an article, you can't really have good medical care without medical thinking somehow as curation.
Well, I do too, and I wish that NLM would do yet even better than we do. But let me give you an example of something e-patient Dave found that I found quite surprising. He got advice which said to him, okay, now you understand your diagnosis of cancer, and you've got to go to a place that specializes in cancer treatment, but here's a thing to remember. Don't let anybody give you any drug until you get up there and try to get on that IL-2 protocol. I thought that was a very sophisticated piece of advice that I would have expected you have to go to an oncologist to hear, but he didn't. He got it on the internet through some kind of a birds of a feather group.
Yeah. No, so Dave...
In the rheumatology, for example, the birds of a feather people are much, much better advisors than rheumatologists on how to actually live with rheumatoid arthritis and those kind of diseases. I think we all know that.
Well, it's just buyer beware because, my challenge here is I have patients of very different sophistication.
Yeah.
And Dave, MIT-trained scientist,
sure.
And so we have to create educational materials at the 6th to 8th grade level and try to deliver them to patients who may have literacy issues, access issues, etc. So, sure, the internet is a powerful thing. I would never discount crowdsourcing, but let's make sure that we set a bar, set a floor for everybody with great educational materials.
John is practically inviting you to argue with him.
Yeah. So I was going to demonstrate splashing water on my Kevlar suit, but we don't allow water in this building. So.
Question here.
Yes, yes.
In terms of funding, I heard on Friday that from, at a nursing meeting, nursing librarian meeting group, that the stimulus funding includes hospitals and health systems, that long-term care and hospice may not be eligible. What are we doing about continuity of care when we look at records? Getting them to the people who are the caregivers for people who are no longer able to care for themselves. Maybe not end of life, even rehab. All rehab today goes on in long-term care facilities if it isn't in the home.
Right, so this is a very good point. As written, meaningful use, the stimulus dollars apply to eligible professionals and apply to hospitals, and LTACs and SNFs are not included. John Durr, who represents a variety of long-term acute care and skilled nursing providers, is on the standards committee with me, constantly looking at the information requirements of those organizations. And I wrote a blog, actually, with John a couple of weeks ago called Meaningful Use, Data Exchange, and Long-Term Care. So we delineate all the things that we hope will happen. The one thing meaningful use does require is that the hospitals send a summary of the inpatient stay to the next provider of care. So our challenge is long-term care today doesn't get reimbursed in any special way through stimulus dollars, but at least the hospitals should be sending those coordination of care documents to them. And there is quite a lot of work going on to try to expand meaningful use as we look at 2013, the next stage, to embrace hospice, long-term care, and skilled nursing facilities. And the goal of all this is care coordination, where your lifetime record should follow you no matter where you go.
And it should be more than drugs and surgery. It should include nursing, therapy, treatments.
Right, and this is that whole standard...
Education piece as well.
Right, well, the whole standards thing I was trying to get at is it isn't just a problem list, a medication list, an allergy list. You need more narrative, you need more of the complete interpretation of the clinicians as to their thought process. That should be included too. I think there was another, yes.
Oh, I'm just curious. If I wanted to go look at your secret genes, where would I go to look for it?
Personalgenomes.org. And it's 750 megabytes. And so if you actually think from an informatics perspective how to represent 30 billion base pairs where there are only 4 base pairs, the answer is the 750 megabyte file. So the New York Times asked to see it, and they said, but wait a minute, it's just a bunch of A's, T's, G's, and C's. As opposed to what? But so personalgenomes.org, and you'll see I'm patient number 2. It's all downloadable. Yes.
Push the button, please.
I'm sorry.
There you go.
Okay, the physician is one of the few people who's licensed to make life and death decisions on a narrow database.
Right.
How do you cope with the physician who saw one utilizing all of the resources of his handheld, and then for the next 5 relies on his ever-failing memory?
Yeah, no, so this is actually an important point. So let me just give you an example. Why is it that I would dose heparin as a 5,000 unit bolus and 1,500 units per hour? Because my chief resident in 1989 told me that was the way to do it. Well, so today in provider order entry at Beth Israel Deaconess, there is no heparin dosing. You simply say, I want to order anticoagulation for this patient. And so we have in the New England Journal an algorithm that looks at creatinine clearance, body mass index, and computes for you in a customized fashion based on the patient's body parameters the right way to anticoagulate them. And we do this time and time again with decision support rules, protocols, and care plans. Chemotherapy is no longer ordered on patients because that's really problematic. You instead say, here is a protocol. Here's the disease state, here's the protocol, and then the computer is calculating all aspects of hydration and emesis treatment, the chemotherapy regimens, and all the rest. And our 2 full-time research nurses keeping that updated continuously to the best practices in the literature. Only downside of doing this, November 13th, 2002 at 1:45 in the afternoon, not that I remember that precisely, all the networks of Beth Israel Deaconess went down. The hospital went dark. We couldn't order a test. We couldn't view an image. The interns had never handwritten an order. It's like, oh my God, there's no computer. What do we do? I don't know. And so the challenge, although we build these fabulous decision support systems and have the data constantly updated for the latest care plans, is what if the technology isn't there? And my answer to that is I now have multiple cloud computing data centers with replication of petabytes of data in multiple geographic locations, so the systems just don't go down. But there's also a big education piece to this, and as you point out, we somehow need to be able to deliver that knowledge in a persistent mobile fashion in the case that the bigger decision support systems go south. Ideally, we never want a clinician to rely on their either failing memory or the fact that medicine is an apprenticeship. We've learned based on the last 3 cases we saw, as opposed to what the evidence might suggest. And I hope comparative effectiveness and increasing decision support in our systems eliminates the need for clinicians to have an apprenticeship method of learning.
Okay, well, let's present you with a certificate. Now we'll update your implantable.
Okay, hey!
That'll guarantee that everyone will know that you are the Leiter Lecturer for 2010.
Very good. Well, thank you so very much.
You're all invited to come outside and splash water around. See if the Kevlar really
feel
works.
free. I've actually had people in lectures throw glasses of water just to check. Thanks. Okay.